So we're going to look at facet cysts today, and what we normally do when we teach is that we start with normal anatomy, because I think normal anatomy is the most important thing. And then once you know what's normal, then you can look at what's abnormal much more confidently. So if we look at the facet joint is basically composed of the joint between the inferior articular facet and the superior articular facet, and we have the joint space in between. Now, on MR, what you see is this is a PD signal. This is a PD sequence. So we're seeing intermediate signal. On a T1 sequence, you would just see low signal. And on a T2, you may either see a thin amount of fluid in the facet joint, or you may see no fluid in the facet joint at all. And that's the normal appearance. The other important bit is also to look at this. This structure is the ligamentum flavum. So the ligamentum flavum covers the facet joint on its medial side. So we have both a capsule. So this orange arrow is for the capsule. And here we'll have a capsule around the joint. And then this darker structure is the ligamentum flavum. This is a T1 weighted sequence. On T1, it is low signal. So the normal appearance is to have a thin amount of fluid or none at all, and then a thickish black line, which is a ligamentum flavum and capsule. And on the lateral side, we have only capsule. Okay, so where do you get cysts? Cysts are basically due to degeneration of the joint, and you end up with synovial cysts. So there is some connection. Often there's a connection between the cyst and the joint. So if we look at this image here, we have a number of locations where the cyst from the facet joint can go. So it can go into the subarticular recess. We'll go into what that is in a moment. So that's basically within the canal. It can sit in the foramen. It can be in this far lateral or extraforaminal region. So that means it's outside the foramen. Or you can get these posterior paravertebral cysts. Now, the importance of this is that depending on where the cyst is sitting, a different nerve root will be affected. And again, we're going to go into which nerve roots will be involved. Okay, so let's look at a normal case to begin with. Just give me a moment. I'm going to change over to the dicoms. Okay, so we have, I'm just going to go through the normal anatomy of the locations of where these cysts can occur. So I just want to make sure everyone can see the DICOM screen. We've got two windows, sagittal and axial. Okay, I'm not hearing anything. Waihana, if you can just maybe on the chat box.
Yes, it's okay.
Oh, you can hear? Great. Okay, terrific. Thank you. All right. So the way to assess, okay, let's start with normal first. So normal facet joint, small amount of fluid. So this is within normal limits. What's abnormal? Well, it's a matter of degree. Okay, so I think this is, you would say, is within normal limits. We'll see some later on where there's more fluid than normal. Ligamentum flavum. The capsule, we don't really see all that well, but so this will be a combination of flavum and capsule. Now, if we look at the location of these cysts, most commonly what these cysts do is that they come out of the facet joint and they will sit in here. So this region is the subarticular or lateral recess. They will be in this portion of the canal. So what does that mean? What does the subarticular lateral recess mean, and how do you find it? So the subarticular or lateral recess, probably the best look anatomical marker is the pedicle. So if you look at the pedicle, this region is the subarticular or lateral recess. And we have a nerve root that goes in there, and that is called the traversing nerve root. So we're here at 543. So this is the 3-4 level. So this is the 3-4 disc. Now, as you keep coming down, we have two nerve roots. We've got a exiting nerve root, which will be the L3 nerve root, and we have a traversing nerve root, which is the L4 nerve root. We'll come back to this again in a moment, but basically we can have a cyst that sits within the subarticular lateral recess. We can look for cysts within the foramen. We can look for cysts outside here. And the other area which is commonly missed, because we just sort of don't look, not that it's difficult, are posterior paravertebral cysts, which come out of the posterior margin of the joint. And the more important ones are really the ones anteriorly, because they're the ones that can compress nerve roots. Okay, so let's go back now to the slideshow. Okay, so as we said, cysts within the subarticular or lateral recess, they will affect the traversing nerve roots. So the nerve roots that are within the canal are the traversing nerve roots. Cysts within the foramen. So these will now affect the exiting nerve roots at whatever level you're at. And these are lateral cysts, which will also involve the exiting nerve root. And then these are posterior paravertebral cysts. And they come off, as we said, from the posterior margin of that facet joint. Okay, so we briefly talked about this before, which nerve roots are compressed. So if we go back now to the dicoms, so let's use this L3-4 level as our standard. So we're at the 3-4 level. The nerve root that's within the canal, the first nerve root. So we've got a whole lot of nerve roots here. And the normal nerve roots, you know, are like the quadriquina. So they come off sequentially. So this will be, sorry, let's go down here. So this will be the L4 nerve root. This will be the L5 nerve root. So they go out sequentially. So if we're at this L3-4 level, the nerve root the first nerve root that's there in the canal is going to be the L4 nerve root. The nerve root that comes out is the L3 nerve root. If we go down to L4-5, here's the L4 nerve root that's gone out. This is the L5 nerve root that's within the canal. This is the traversing nerve root. And this is the one that will get affected if we have a cyst in the subarticular recess. The exiting nerve root will get affected if we have a foraminal cyst. Okay, let's go back to our PowerPoint. Okay, so we've talked about which nerve roots are involved. So what do we look for? So we're going to look at both the MR and the CT appearance. On MRI, basically what you're looking for is a cystic structure. This is going to be the most common appearance. We'll look at some variations on this, but the most common appearance is going to be the cystic appearance. So what you're looking for is usually a pretty well marginated. So it's got this low signal rim. This is a T2 weighted sequence. So the cyst is bright. This is T1, cyst is low signal. And this is a very typical appearance of a facet cyst. Here we have fluid in the facet joint. So the things that give us some indication that there's degeneration in the facet joint is the fact that we have this looks a little bit too much, especially, and it also looks asymmetric. So the previous one we saw, the normal one, it was very symmetric. Here we've got significant asymmetry in the amount of fluid. So this looks like there's a bit too much fluid in here. What about if you gave contrast? So if you give contrast to a cyst, they may or may not enhance. And the reason they can enhance is because the cysts are actually continuous with the joint space, with the facet joint space. So you can get synovialization and you can get normal enhancement. So usually that enhancement is peripheral. And the other important thing is because the question will always come up, is this an infected cyst? Is it inflammatory? Is it infected? If there's and we'll look at infection towards the end of this talk, but one of the things is that when you give contrast with infection, generally you will see the peripheral soft tissues around the cyst also enhancing, or they will have inflammatory change. It would be really unusual to have an infected cyst and not have any soft tissue changes around it. So that can also help you. But I think the thing is that if you happen to give contrast, now something like this, you really don't need to give contrast. But if you happen to give contrast and you see enhancement, it shouldn't put you off calling it a cyst. So given the location of it, the appearance of it, the fact that it enhances, it's still a cyst. Some variations in it, so they can be septated. If I go back here, this one, it doesn't really look septated. There's a bit of heterogeneity in its signal, which is normal. But if we look at this case, we've got septation within the cyst. Now, again, that can be found. It's not abnormal for the cyst. So this wouldn't be something that you would think I'd say, oh, it's got septation, maybe it's tumor. Septation can be seen with cysts. Okay, so how do you actually assess for a facet cyst? I think the places to look are, you need to look on sagittal and axial. And on sagittal, you need to start medially. You need to actually start within the canal. And I'll show you why in a moment. But basically, you start out within the canal. Then you need to look in the foramen. Here's the exiting nerve root here. This is the exiting L4 nerve root. And then we look as far laterally as we can on the sagittals as well. So it depends on your field of view, how far laterally you go. But this is, we go out as laterally as possible. The other thing is that you then also look at these posterior areas. So this is where you're going to get these posterior paravertebral cysts, the ones that don't involve the nerve root. If you happen to see facet degenerative changes as you're scrolling through the scan, or you happen to see fluid within a facet joint, that sort of slightly increases your suspicion that there may be cysts. They don't always happen with this, but it's just if you see that, then there's a bit of a higher chance that you will find a cyst. Okay, so let's go back to this DICOM, and I'll just show you the method of going through. Okay, so what I would do normally on the sagittals is that you would look, so here we are in the midline, and the small cysts often you will see here as they just, so if you can see where we are, right? We're at this, we're just at the margin of the facet joint. So these small cysts often they bulge out like this, and then on the sagittal scan you will see a cystic structure that's sitting within the canal. So this is one area to look. And then as we keep going more laterally, then we're right into that facet joint. So we're now looking at the foramen to see if there's any cystic structure. And then as you go out as far laterally as possible, look for cysts out here. Also look for cysts in these regions, in this posterior aspect of the facet joint. And when we look at the axial images, where are we going to look? So those same places, again, subarticular recess, foramen out laterally, and then also at the posterior margins of the joint. So let's go back to the PowerPoint. And we're going to start looking at some cases. So let's look at these. Okay, so let's have a look at the sagittal scans to begin with. So what we notice is basically facet degenerative change. What's a normal facet look like? Well, here's a relatively normal facet. And then if we look at the facets lower down, you can see that there's an overgrowth of facets. So, so there's a slightly increased chance that we might find a cyst. Let's keep going. And what you notice is as we go sagittally is that then we see this cystic structure sitting within the canal. And this is a common area to see. It is sort of just at the sides of the canal on the sagittal scans. So now let's look at that on the axial images. Okay, so let's start above and work our way down. So we've got a little bit of fluid in the facet joints. Come further down. We've got facet hypertrophic changes. The ligamentum flavum is a little bit thick, and then we have the cystic structure. So how would you describe this in the report? Well, you'd say that there is a well-defined T2 hyperintense structure measuring whatever, so 2 planes measurement, and the third plane supra-inferiorly, which lies within the canal at the L5S1 level with indentation of the thecal sac. So here's the thecal sac. And now which nerve root is going to be involved here? We're at L5S1. Which nerve root will be affected? It'll be the traversing nerve root. So the traversing nerve root is the S1 nerve root. So we would say that say all those things about the cyst, and then at the end you'd say that there is compression of the traversing left S1 nerve root. Okay, and then if you keep going further, you see S1 here. So here's S1. It's now mixed up with that cyst, or it's compressed by the cyst. But if we go further down, now we get into S1 here. So the way to describe, so it's a lot of, with a report, any report, should be very descriptive in the sense that when someone's reading it, they don't really even need to see the scan. So if you describe this as, as a well-marginated cyst, sitting in the subarticular/lateral recess arising from that left facet joint and compressing the thecal sac and the traversing left S1 nerve root, that's really everything they need to know. Let's look at a different case. Sorry, I think I got it wrong. Okay, so let's look at, let's come back, we've got 9 and 10. Let's look at 10. Okay, so we have let's look at the sagittal scans again. So when I'm looking at a lumbar spine, I generally start with the sagittal scans, which is why I'm saying sort of look for it on the sagittal images, because you just get a sense of it straight away, and then you can assess it further on the axial images. So let's look at it on the sagittal images. So nothing's sort of really jumping out here at the moment. So now let's bring the axial images. And what do you see here? So let's put we're at this L5S1 level. And here we've got a really small cyst, which is sitting within the foramen. So now let's find that again on the sagittal scan. So it has to be there on the sagittal images. And this is it here. Okay, so you can see that we're cross-referencing with that cyst. So this is really tiny, and it's very easy to miss this. Okay, so as you went through, it's really easy to miss it. So it doesn't matter as long as you found it on the sagittal scans. But on the axial scans, but what I would do is that once I've found something in the axials, I'd go back to the sagittal and make sure I can see it, because the next time I want to be able to pick it up on the sagittal straight away. So we have a small cyst. So we've said that we've got a cystic structure. Let's look at the T1. So again, it's important to look at the T1 and compare signal, make sure that it is fluid signal. Okay, so it's low signal on T1, high signal on T2, slightly septated, sitting within the foramen. So all of these things fit for a facet cyst. So the next thing we need to know for our report is what's happening to the nerve root. So the nerve root that goes out here, we're at the L5S1 level. So this is going to be the L5 nerve root going out. So we have indentation or contact with that traversing left L5 nerve root. Okay, so again, we'd give the cyst measurements. Let's just go back. Let's have a look at something else. So what we've said is that our normal sequencing is at T1 and T2. And when you get small cysts like this, they can be pretty hard to see on the T2 because the signal is the same as fat. So we don't have any contrast between the two. So then what we need to do, what is helpful is to use a different sequence. So normally in our spine sequencing now, we will add some sort of T2 fat set or a stir sequence. And that's really to bring out signal. Okay, it's not for anatomy, it's predominantly to bring signal out and take your eye to where some things are abnormal. So let's have a look at this. Just give me a moment. Sorry, I just lost it here. Okay, so let's look at this one. Okay, so here this patient has got facet cysts. This is a T2. This is a T2 fat set. So let's not have the T2 fat set for the moment. Let's just look at it on the T2s. So I want to just want you to look at the posterior paravertebral region. So if we're scrolling through here are some posterior paravertebral cysts, but they're pretty small. Okay, very easy to just go past them. Let's look at it now with the fat set sequence. Okay, so this is on the fat set, and now this is really let's take this out. If we look at this sequence, this is really the only thing that's bright now. There's nothing else bright in here, whereas on the T2, you've got lots of fat signal, so it's much harder to see. So now for our spine sequencing, we will do some, either a sagittal or a coronal PD fat set or a T2 fat set or a stir. It doesn't matter. Stir is also fine. Stir is easy, and stir is also fast. So a stir is a good sequence. But what you're looking for is for that signal to jump out and hit your eye. So it's much easier to see this than it is on the T2. because on a T2, we have adjacent fat signal and we don't have as much contrast between the two signals. Sorry, I don't know whether you saw that. Did I share that? I think I did. Let me just check. Yeah, go ahead. Sorry, I'm not, can I just make sure that you actually saw those scans that we were showing?
Yes.
Yeah, you
just
saw
now
this.
Was a little bit frozen, but I think now it's okay.
Okay, I'll just very briefly go through it. So sorry, what I was saying, I'm not sure if it was sharing, but basically what I was saying, there's on a standard T2, you will see these cysts. I mean, these are small, but they are easy to miss. If you do a PD fat set or a stir or a T2 fat set, these just jump out at you. Okay, you don't need to work hard. And that's always a good thing, not having to work too hard to find something, which means you also don't miss it. So as a rule, I for spine sequences, add some sort of T2 PD fat set or the T2 fat set, PD fat set, or a stir sequence. Okay, what about CT? So CT is not as useful because the contrast of CT is the same. So the cyst will be the same as what's in the dura in the thecal sac. So facet cysts are often missed on CT, but there are a couple of things that can help you, which are not common but can help. So if you see air within the canal, so we've got a nice rounded structure here with air. We also got air within the facet. So this suggests that there is a cyst within this. This is related to that. So there's air has leaked out of that facet joint. It's now sitting out here. So this is a good appearance for a facet cyst. The other thing that occasionally you will see is calcification of the cyst, and this will be seen better on CT than it will be seen on MR. And we'll go into that in a moment. But on CT, for facet cysts, predominantly, if you see gas within the thecal sac and they've not, within the canal, and they haven't had recent surgery, then you need to think about a facet cyst, especially if it's right up against the facet joint, but they can track. And if you see the sort of rounded calcification around the region of the facet joint, again within the the spinal canal, this is also a calcified facet cyst. What about on MR? So MR, seeing gas is difficult because air does not have signal. So these are the same patient, both scans from the same patient. We've got gas within the canal, but here it's impossible to know what this is. Okay, this could be calcification, it could be ligamentum flavum, it could be gas. You don't know. So luckily we had a CT as well, so we could work out that that was actually air. But it can be very difficult on MR to diagnose the presence of air when it's small like this. Let's look at that case. Okay, so here we've got, let's look at the CT first, because I think that makes it easier. Okay, so we have air within the facet joint. And then on the sagittal scans, and again, as I said, the sagittals are important. Look at the paramedian plane. So here we've got air within the canal. Let's start. And here's that little cystic sort of structure with gas within it. and it's right up against the facet joint. So if you see this on CT, I think this is a facet cyst. I think that's the only thing you're going to talk about. What about an MR? Let's go to the. Okay, so this is it here. But there's no way on MR, if you only had MRI, that you could make that diagnosis. Because this really, as we said, it could be calcification, it could be a very thick ligamentum flavum, it could be a very proteinaceous cyst. So it's not possible to make the diagnosis in MR. You really need a CT. Let's look at a different case. Okay, so this is the one where we have calcification of the cyst. Let's look at the CT first. So here's the calcification. So what's important on CT? One is that it's rounded. We have calcification. It's sitting up adjacent to the facet joint. It's in the subarticular lateral recess. And we'll have compression of that traversing nerve root. Let's look at it on the MR. Okay, so this is the appearance on MRI. So I think on MRI, you can't tell that this is calcified. You really need a CT to work that out because we have that low signal black rim, which we have normally with a synovial cyst anyway. And we can't really make that diagnosis of calcification on MR. So they're complementary. You know, I think if you didn't have the CT, you would just say that this is a synovial cyst with which is complex, but you couldn't really bring up the thought of whether it's calcified or not because you can't tell. Okay, so we've gone through that. And the last one we want to talk about is proteinaceous cysts. So all the cysts we've talked about so far are fluid, have got fluid within them. So they are low, they are high signal on T2. Sorry, that's my dog out there, which is barking away. I think that there's a big storm here at the moment. There's a lot of thunder. So we've got, what we've said is that most cysts are going to be fluid signal. Okay, they're high signal T2, low signal T1. Occasionally you'll get some septation. But sometimes what you see are very proteinaceous cysts. So the content of the cyst has a lot of protein in it. So what that does is that the signal increases. So here, this is a T1. We've got very high signal. T2, it remains high signal. So on this, it's potentially, it still just looks like a normal cyst. But if you go back to that T1, this is not the behavior of a simple cyst. A simple cyst will be low signal. And then this is a post-contrast. But it's importantly also, it's fat saturated. So what are the possibilities here? That on this T1, this is fat, doesn't fat saturate. It can be, I mean, there are tumors that can give you high signal, but we're not really talking about tumors here. So this is high signal, which doesn't fat saturate. This is the appearance of proteinaceous material within the cyst.
Dr. Rafi, you have 2 minutes more.
Okay, excellent. Let's keep going. So we won't look through the DICOM on that. We're just going to talk about one last thing, which is infection. Now, facet cysts can get infected, but generally it's not the cyst itself. What happens is that you end up with a facet joint infection, and then you can get cysts developing, infected cysts developing around the facet joint. And again, if we look at this images here, this is a T2 weighted scan. Here's the cyst, but it is very hard to see it, okay, because we've got fat on either side. But the thing that is important here is that if you look at the signal of the muscle, so these paraspinal muscles, this is the normal low signal, but on this patient's left-hand side, you have increased signal within the muscle. So here, that is a clue to something is not quite right. But the issue really is that on these standard T2s, it's very difficult to see. It's T1 also, it's difficult because muscle is also low signal. It's very hard, it's very easy to just scroll past it. But when we give contrast, what you see is that you've got these multiple cystic structures which are not enhancing. So these are the cysts and abscesses around the infected facet joint. And this is the inflammatory and infective change within the adjacent soft tissue. So we talked earlier on about infective changes or inflammatory changes within the cyst. Generally, what you will see is that you will see spread of that into the adjacent soft tissue. So you should see some abnormality in soft tissue. So this person had a facet infection, facet joint infection, and developed multiple cysts in the paravertebral region, which is what we see here. So having just a facet cyst, it's uncommon for just the facet cyst to get infected. It's usually there's an underlying facet joint infection. Okay, so just for time, we won't go through that. Why don't we look at, go through any questions people may have?